Uh, Thank you for everybody to join this webinar, and a very warm welcome to the London team who accepted our invitation. My name is Gyula Tövisházy. I work in Budapest, Hungary, at Szent Marton pediatric ambulance team. And this joint webinar is a start of a one-year series where we want to build some international relationships, and because of our 25th anniversary at our service, we try to reach not only Hungarian people but also people in other parts of the world as well. So thank you for being here, and let me introduce my colleagues. So we are going to do this in a maximum 2-hour session today. The first two speakers are going to be here from the London team. So please welcome Isabella Wright. Izzy is a transport nurse specialist from London. So thank you, Izzy, for being here. And the second speaker is Dr. Amira Zahari. She's a CATS consultant, and she was very kind to step in. There was a slight change in schedule, but the topic and the main aim remained the same. It's about pediatric upper airway obstructions. You will also have time for questions, and then the Budapest team is going to do the second part. So after my part, my colleague Clara Horvat is going to speak about statistics in Krupp syndrome and some audit what she did. Clara is a pediatric intensivist here in Budapest, working in Semmelweis University. So thank you, Clara, as well. And two more technical things. So the webinar is going to be recorded. It's going to be available on the CACTS website, which you see here. And there is a very strict GDP regulation. So please, if you ask questions, do it in the Q&A option, and do it anonymously, so that it's remaining safe from that point as well. So I now stop screen sharing and give it over to Izzy.
Thank you for that introduction. I'm just going to share my screen. Here we go. Okay. Okay, hopefully everybody can see that screen. Can you see it?
Yes, it's fine.
Yeah.
Thank
Perfect.
you.
Okay. So yeah, thank you for the introduction. My name is Izzy. I'm the transport educator for the Children's Acute Transport Service based in London at Great Ormond Street Hospital. I'm going to present to you some information about our service and how we run, the types of referrals we see, and how we function as a team. So who are we? We are the Children's Acute Transport Service. We are a referral-only critical care transport service for children based in London. We have been established since 2001 in collaboration with the paediatric intensive care units across the North Thames region. There are 12 similar services across the UK that we work quite closely with, and we transport about we have about 6,000 critically ill children that are transported nationally between those similar services, and CATS transports about 1,200 of those cases a year. We also offer expert advice and educational support to the district general hospitals that are within our region, and any other calls that we take, which sometimes are national and also international. So at CATS, we have the ability to do land and air transfers. We have 3 bespoke ambulances as part of our fleet, and these all have bespoke stretchers as well, set up for the transfer and care of a critically ill child. We have a patient support unit vehicle, which we use to take teams out quickly to help relieve teams that have been working sort of overnight, and if we need to get a consultant out to a patient quickly. We also have the ability to fly some of our patients. So we work alongside the Children's Air Ambulance. We also work alongside Bristow, and we have the capacity to do fixed wing transfers as well. And you can see some images there down on the left-hand side of our patient support unit and the fixed wing that we use sometimes. And then we also have a Bristow helicopter on the right-hand corner. So we are based at Great Ormond Street Children's Hospital. We cover 17 district general hospitals within the North Thames region. So if you look on the map here, you can see the river which separates the north from the south. And alongside these district general hospitals, we also work very closely with the intensive care units across London. So that includes Great Ormond Street Hospital, and they provide a paediatric intensive care unit, a neonatal intensive care unit, and a cardiac intensive care unit with ECMO. We also work alongside St Mary's Hospital, the paediatric intensive care unit, also known as an infectious diseases hospital. They also take a lot of trauma cases as well in paediatrics. We work with the Royal Brompton Hospital. They are also a paediatric intensive care unit, cardiac intensive care, and have the ability to provide ECMO as well. We have one dedicated unit for high dependency care in the North Thames region, which is at Chelsea and Westminster Hospital. However, there are some HDU beds in the district general hospitals that we work with in our region as well, but this would be our standalone HDU unit. There's also the Royal London Hospital, a paediatric intensive care unit, which offers expertise in trauma. Alongside the hospitals within our region, we also work with a lot of neighbouring services. So we're well connected if we need to transfer a patient out of region, or if we have to support other transport services with bed finding. And you can see here on the left, we work alongside Embrace, which is based in Yorkshire, Kids, which is based in Birmingham. We've got Nectar in the northeast of England, Nista, which is based in Ireland, Newts in northwest of England and North Wales. There's PICS, which is also the National ECMO Service at the moment, and they can transfer patients on ECMO. There's the South England service as well that PICS cover. And then up in Scotland, we work with Scotstar. They cover the Scottish mainland and island, also the Outer Hebrides up in the Scottish region. And then there's Watch, which covers the Western Acute Transport area, so Bristol. And then within London, we work very closely with Panda, who cover the East Anglia and Cambridge area. There's STRS, which cover the South Thames region. There's a neonatal transfer service also based in London, and there's Southampton and Oxford retrieval teams as well. Here at CATS, we are very fortunate to have a very, very well-established, experienced team. We have our operational lead who covers the nursing and advanced practice, and we have a medical specialty lead as well. Our medical team is made up of 6 consultants who are a mixture of paediatric intensivists and anaesthetists as well. We have locum consultants that support us from the neighbouring paediatric intensive care units that I mentioned earlier. And we offer a rotational programme for clinical fellows who can spend up to 6 months with us on a programme. Our nursing team is made up of 8 core nurses who are full-time. We have 4 qualified nurse practitioners, 1 nurse educator, and we also open the service up during the winter time due to the winter pressures for to have 2 extra nurses in our service to help with that surge. We are very fortunate to be supported by about 20 nurses from the regional ICUs within our area as well. And they rotate in from their permanent place of work and cover a couple of shifts a month for us. But the true backbone of our service is the ambulance technicians and our office managers and administrators. So whenever a referral is made to CATS, you will first speak to the administrators or the office manager, and they will manage and help triage any of the calls. And of course, for us to be able to do our job, we absolutely need our really experienced ambulance technician team who work alongside St. John's Ambulance. So there are no hard and fast rules about how to refer a patient to CATS or who can be referred, but our primary role is to transfer children who require paediatric intensive care in the North Thames region. We work with neonates and children up to the age of 16 years. We can transfer children over at a minimum of about 1.5 and above kilos. We transfer children with duct-dependent lesions, ECMO requirement, liver or vein of Galen diagnosis. And if our capacity allows, we are able to also transfer children who require HDU and whose care may not be particularly, who may not require paediatric intensive care, but a transfer may be necessary by the CATS team. We support with repatriations, non-surgical and non-cardiac neonates as well. So a little bit of information about the type of referrals that we see. So this is some data and statistics that we've got from January 2023 up until just gone January 24. So we've seen about 2,127 referrals, and about 1,201 of those have been accepted for transport. We provide advice, about 33% of our cases we provide advice for, so about 697 of those over the last year we were able to support the team and close on advice, and they did not require a transfer. For the cases that we've not had the capacity to do the transfer ourselves because of not having a team available due to them being already out, we pass over to our neighbouring services, which is the South Thames region and also the neonatal transport service. Sometimes we see the referrals are cancelled. That might be because they've gone out of region or for any other reason from the referral, but we always chase up our referrals within 24 hours. Sometimes our cases are refused, so that makes up for about 6% of our cases, and that might be because they're a HDU transfer and we haven't had the capacity to do the transfer. Neonatal, that could be done by the neonatal transport service if they're out of scope, so somebody like ward transfers, if they're elective or planned, and whether they are time critical. So time critical transfers, we encourage the local team to use the ambulance service to do those if capacity permits. And the reason for that is because they are able to sometimes move the child quicker as we have to get to them and then transfer. Sometimes we have no beds and we're unable to do the transfer, so we ourselves, so we support the neighbouring units with bed requests. And unfortunately, we also see patient deaths within our referrals. Fortunately, that is a small proportion of that. If we look at our referrals based on diagnosis, we can see that we have a very varied diagnosis within our patients, but primarily we see children with cardiovascular instability, respiratory instability, and neurological as well. We particularly see an increase in respiratory over the winter months. So at CATS, we are committed to providing high standard and high quality of care, and we adhere to our KPIs set out by national standards, so the Paediatric Critical Care Society, and they set out some quality indicators that we work against, and we submit data to them for national auditing. So you can see here that some of these quality indicators are ensuring that we aim for a mobilisation time of under 30 minutes. So that's getting our team out of the door and mobilising them to the patient. Keeping our time to the bedside under 3 hours. And this is where we look at things like potentially passing on to a neighbouring transfer service, or considering the use of a helicopter to reach the patient quicker and to get them to the destination quicker as well. We also have to keep a percentage of our refused patients and the reasons for why we've refused them. And we also keep a close eye on the patients that we transfer out of our region and why that might be, and how we can improve that in the future. At CATS, we also work towards some low key performance indicators. So we like to try and aim to keep our activation time. So that's the point of which we are mobilized and out of the door. And we like to keep that under 20 minutes. And this is a good target for us because it helps us keep under the national target of 30 minutes as well. We also aim to keep our stabilization time under 120 minutes. Of course, this is very dependent on the clinical requirements of the patient and isn't always possible. At CATS, we also do daily audits in the morning. We have our CATS forum, and we look at risk and governance quarterly. And we also have the M&M, where we discuss a lot of our cases as well. And this is how we benchmark nationally and locally. So some of the challenges that are presented to us at CATS are the daily surge. So we may see an increase in our the patients that we are being referred. This might be due to winter pressures, so an increase in bronchiolitis and other winter viruses that we see. Sometimes we have capacity issues such as no PICU beds, and this is where we start to look at why that might be, what's going on in the region, and whether we need to consider going out of region. We also have capacity issues of our own, such as not having a team available due to them being already out. Maybe they've run over the time of at the end of their shift. So it's very important that we keep a close eye on this. And we also have collaborative working. So as I mentioned before, we work really closely with the neighbouring teams and we support each other. So often we are referred patients from other neighbouring teams, and we either support them with the transfer or with a bed request. And likewise, we can call on them for help if we need to. In terms of the education that is external at CATS, we often present international education in the form of webinars. We work really closely with with outreach at the district general hospitals. So each district general hospital within the North Thames region is allocated a consultant and a nurse, and we follow up on cases, and we provide regular education for those hospitals. This is great because it also helps us keep a good working relationship with those teams. We also train the paediatric intensive care staff, and that includes anaesthetists, paediatric intensive care fellows, and nurses as well. We hold regional study days. We also teach on university courses, and we offer an observer placement to anyone who inquires. So we're able to do that via the CATS website. Internally, we are providing simulation on a regular basis for our team. We provide education for the rotational nurses who come into our service. We also work with external companies such as Survival Wisdom, which I will mention later in the presentation. A lot of our nursing team and medical team work as advanced paediatric life support instructors. We provide debrief and reflective discussions on particularly difficult cases, and we do this quite regularly after we do hot debriefs, and we can also do cold debriefs where we discuss at a later date. And we have regular teaching in the mornings at CATS. So every week we will have a 20-minute teach, either led by a fellow or a consultant, and sometimes some of the nursing team as well. So as I mentioned before, Survival Wisdom Training is an external company that we work with at CATS. And the reason for this is they are able to provide us with the skills and expertise that we are required in CATS to be resilient and adaptable to the unexpected things that often come up in transport, as I'm sure a lot of the transport practitioners in this presentation are aware. It helps us to enhance team working skills, improves the confidence and capability of our team, and assists with communication and prioritization in different circumstances as well. So as I mentioned in the education slide, we provide simulation. So we often provide clinical simulations such as emergency evacuations. We recently undertook an audit into our evacuation times and implemented a strategy to help us improve our evacuation times from 3 minutes down to 30 seconds or less. So we regularly hold these update days. They're held 2 in the springtime and 2 in the autumn, and that's for all of our staff, particularly those who are on a rotational basis or who are passing through, to be able to equip them with the skills they need in case of a non-clinical emergency. And alongside this, we're able to provide office-based simulation of the evacuation. So this includes visual aids to prompt awareness of the risks surrounding non-clinical emergencies. So some examples of this might be an engine fire, a flat tire, or coming across a road traffic accident. As I previously mentioned, we work closely with the Children's Air Ambulance. So we have regular annual training days where we're able to attend and have helicopter-based clinical and non-clinical emergencies. This is a great opportunity for us to be able to collaborate with other national transport services. And we're very fortunate to be able to call on their support when we do need to use them. We take very seriously the well-being of our staff at CATS, as I'm sure those of you who work in transport and in critical care, it can be a very challenging environment. So we equip our staff to make sure that they have the safe working environment, and we have redundancies built into our team to support them when they are working remotely. So this includes things like access to food and drink, access to phones that will be able to contact back to base if we need to, the training to be able to manage major incidents should they occur. We also have some awards at CATS. So we have the Cassie Award, which we give out to staff for their contribution to non-clinical work. So things like education, research projects, auditing, things like that. But then we also have the Golden Retriever Award, which is what we give out to our staff who have had a particularly challenging transfer. If you are interested in some of the resources that we use at CATS, you can visit our website, and on here you'll find the clinical guidelines, some of our standard operating guidance. We give this website out to the district general hospitals as well, so they have access to the electronic drug calculator, and that just helps them with managing patients on drug infusions that they may not be familiar with using. And on the website, you can also find information about our webinars, the outreach sessions that we do, transport and study day courses that we are holding. And if you were interested in an observer shift, you can also contact us through the website. Okay, so that's a brief introduction to our service. And I think, looking at the time, I've got a few minutes for any questions if anybody has any.
In the meantime, can I ask you one? Is it? Actually, I was really fascinated on your education courses and also the clinical governance you mentioned. I think we have some room for improvement here. Is the wider team you mentioned involving also young doctors who just come for a few months practice, or is it a more stable team which everyone stays for years in the service?
So the core team is made up of consultants and nurses, and they are with us on a permanent basis. We rotate clinical fellows in regularly, sort of every 3 to 6 months. So they are the members of the team that change frequently. All of the courses that we provide at CATS are open to them, but they are usually only with us for a short amount of time. Does that answer your question, Gula?
Absolutely, thank you. Actually, I see now currently no questions in the Q&A. So maybe we can go on with Amira, and then maybe if some questions do arrive, then you can ask for them later as well. Is that okay?
Okay. Yeah, no problem. I'll pass you on to Amira.
Thank you very much.
Thank you.
Amira, I think you are muted now. Okay.
Thank you. It's all right, I haven't started quite yet. Good afternoon, everybody. My name is Amira. I'm one of the CATS consultant here at Great Ormond Street Hospital. And I just had to say thank you to the organizing committee for today's education program. It's been a lot of work, I understand, over the last weeks and months. So I feel quite honored to be given this opportunity to teach you today about upper airway obstruction. I do have to say special thanks to Dr. Linda Chigaro, who's our clinical lead here at CATS, because there are some parts of the presentation which she has contributed to, and also all the other team members who've helped me put this together in the last few days. Just trying to move on to my slides. Oh, yeah. Okay. Lovely. So the aims and objectives of my session, which hopefully should cover in the next 30 minutes, is to review the CATS data on upper airway obstruction, specifically over the last year into 2023. I'll do a very brief overview of the differential diagnosis of upper airway obstruction, because I understand that Gula is going to speak about that in more detail later on. I want to go over the local challenges that we have in managing these cases, specifically at CATS. And to help me with that, I'll go through a very interesting case that we had over the last month. And also we'll talk about the considerations for transport when we do have these cases referred to us. So in 2023, of our close to 2,000 referrals that we received, of that, only 35 was related to upper airway obstruction. And this can be anything really, from stridor to foreign body inhalation to mediastinal mass, and so on and so forth. So you can see how actually within the workload that we receive within 1 year, that's a very small proportion. Only 2% of that is due to upper airway obstruction. Within that, though, half of the time the patient is transported, the other half they are not transported. So last year we did 16 transfers for upper airway obstruction, which was 46% of the cases. I'll briefly go through the causes of upper airway obstruction, and mainly just so that I can highlight how varied the differential diagnosis can be when we're dealing with things when they're referred initially as upper airway obstruction. And depending on how you classify the causes of them, you can essentially get a non-exhaustive list of causes. So you can either think about them through an acute, subacute, or chronic onset. You can think about them from a congenital or acquired onset, or you can even think about them structurally from intraluminal, luminal, and extraluminal causes of upper airway obstruction. The next few slides is purely just to show you, again, the varied differential diagnosis that we can have. So even within the acute and subacute courses of upper airway obstruction, you can most often see infection as one of the reasons. Foreign body aspiration, not infrequent either in children, but you also need to consider more rare things like anaphylaxis, vocal cord dysfunction, and trauma as part of your acute and subacute causes. When you think about chronic causes, you'll start to think about whether this child was born with an upper airway obstruction, a structural anomaly that's caused them to have that. And when you think about that, you can consider whether it could be laryngomalacia, laryngeal malformations, vocal cord paralysis, vascular ring, or any other congenital anomaly. And again, this is a very varied slide of differential diagnosis. There are also chronic but acquired causes of upper airway obstruction. And again, it's not too dissimilar to the congenital chronic causes, but again, this would have developed over the child's lifetime. Okay. So the local challenges of upper airway obstruction is essentially managing anxiety, not only within the patient and the relatives, but also the clinicians that refer these cases on to us. We know that from our mainstay way to assess a patient is A&E, A to E. So airway represents the first thing that comes into mind when you're worried about a patient. And if someone is coming in with signs of upper airway obstruction, generally speaking, it's going to cause a lot of anxiety amongst the clinicians and the allied healthcare professionals. So part of what we do at CATS is to provide them with critical care information in terms of resuscitation and stabilization, but also to reassure them and manage the anxiety locally whilst we work through the case during the referral. The other local challenges that we face specifically with upper airway obstruction is the availability of ENT and pediatric anesthetists, specifically out of hours. Most of our local district general hospitals have some form of services of these specialties during the Monday to Friday daytime, but during the nighttime and the weekends, these are almost always non-existent, and therefore we have to then coordinate our care with the specialty centers which do have these specialties. And we do that through an MDT approach, and we have the ability to do conference calls so that we can tie together all the different specialties to come up with a management plan for a safe transfer and for safe management of any patient that comes through with upper airway obstruction. I'll present a case that hopefully will highlight the challenges that we have faced, specifically with upper airway obstruction in the past. And as we'll go through that, I'll talk about the differential diagnosis and also how we manage this case. So not too long ago, we had a referral from a local hospital of a 13-year-old boy who was previously fit and well and is quite active in sports. But within the last 3 to 4 weeks before presentation, he had developed a productive cough. And within this time, he was also febrile. The parents sought help at the general practice. So this is the primary care service that we have in UK. And during those visits, he was treated for a chest infection, and he received actually 2 courses of antibiotics with no relief of his symptoms. He was then brought to A&E on a Friday afternoon because of shortness of breath. When he came in, he was found to be self-ventilating in air. He was mildly tachypnic with a respiratory of 22, but saturating well at 97, though they did note that he was short of breath when he was talking. He was slightly tachycardic and his blood pressure was a little bit low, so they gave him a 10 ml per kilo fluid bolus, which did help and bring his blood pressure up. Because of the concerns of the productive cough and fever for the past month and failure of initial oral antibiotic treatment that he received in the community, he received IV ceftriaxone. Luckily, during this time, he remained alert and his GCS was 15. Other signs and symptoms that they found on examination was that he also had quite pronounced lymphadenopathy. They completed a chest x-ray based on the symptoms, and this is what they found. And obviously what stands out straight away is that he's got a right-sided whiteout with what looks like at least a moderate pleural effusion on that right pleural space. He's also got a marked mediastinal shift to the left. And also just wanted to highlight here is that he's also got compression of his lower trachea. And what's not so evident here is that his right main bronchus is also compressed. So of course, this would definitely cause a lot of alarm in people. When you see this, you're not really sure where to go next. So they called CATS. Our initial advice at this stage, given that he's still self-ventilating in air, he was saturating well, and he was generally cardiovascularly stable, was to see whether we could do a local long ultrasound to just differentiate how big that pleural effusion is and whether it will be amenable to drainage in order to help us make him safer for transfer. On top of that, we've seen quite a few cases of unilateral pleural effusion secondary to group A strep infection over the last 18 months in the UK. And as part of that standard treatment, we asked them to add clindamycin. And we also asked, just because of the lymphadenopathy that was present and the history as well as the chest X-ray finding, to examine for signs of SVC obstruction. So that was our initial advice. Locally, they did not have the sonographers or radiographer capabilities to do a lung ultrasound, but they actually did have ability to do a CT scan, because the anesthetists locally were able to assess the patient and that he was safe to lie flat-ish for about 5 minutes, the amount that's required for him to have a CT chest. And this is what they found. This is just a slice of the CT chest. There were lots of different findings that I'll go through in a second, but what I wanted to highlight here was that on the left side of the screen, you can see the red arrow points to a right-sided mass, and this actually is a soft tissue mass that's arising from the first rib on the right side. There's almost complete collapse of the right lung as you go further down the scan. And you can also see at the bottom of that right side in the base that there's quite a lot of fluid as well. The other arrow on the right-hand side of the screen is just to show that the big black hole, which represents the trachea, which should be nice and central, just behind the sternum and before the vertebral body, is actually deviated to the left. Now, based on this CT scan, we were then starting to formulate a plan of what we should do for this patient. I'll give you about 30 seconds for you all to consider by yourself what are the transport considerations for this case, given the history that I've mentioned, the chest X-ray finding, as well as the CT scan that I've talked about. Okay, so that was about 30 seconds. I know things are probably running in your mind in terms of how am I ever going to be able to move this child safely? How am I going to manage this child? So hopefully I can help guide you through those things. The main points that we considered was where was going to be the appropriate location of care for this child and whether or not they were safe to remain at the local hospital, or do they need transfer straight away? And if they were to be moved, where would be the most appropriate place for this child to go to? I also differentiated the next point between the location of care and the location of the definitive treatment, just because locally, because he's 13 years old, we actually do have a hematology and oncology center who manages cases that present this way. However, given the amount of tracheal deviation, and also what I didn't mention earlier was SVC compression with the large right-sided pleural effusion, it was felt best that he was to go to a pediatric intensive care unit first for stabilization and also for close monitoring, because in the event that he was to deteriorate fairly rapidly, then he would be at a center which has pediatric anesthesia, pediatric ENT, and potentially even ECMO capability backup, should we need it. And then the third point that we strongly considered was how to safely transfer this patient. To kind of summarize, the management that he underwent, he was essentially transferred to PICU the same evening that he was referred. Because he was self-ventilating in air and was generally cardiovascularly stable, we transferred him as is. He was not intubated and he did not require any further respiratory support. As part of our backup planning and our contingency, should he deteriorate en route, was that we had an LMA for an LMA intubation should he need it, which he didn't, thankfully. When he was admitted to PICU, he received emergency chemotherapy, though because this was Friday evening going into the weekend, because of the high risk nature of his mediastinal mass, it was felt best that any other interventions were deferred for the following Monday. And so that Monday, he then underwent a chest drain insertion where they drained 1.5 liters of fluid from that right side of the chest. They did a tissue biopsy and also a PICC line insertion, all under local anesthetic, just with ketamine and other sedative agents. He luckily tolerated that, and with the emergency chemotherapy, there was some reduction in the mass size, and he was stable to a point that he was able to be discharged to the oncology ward before then being discharged home for further staged PET scan and planned radiotherapy at the oncology center, which I mentioned earlier, which is separate to the PICU unit. So that was, I think, one of the most interesting mediastinal mass cases, certainly that I've seen over the last few years. There were lots of considerations, lots of multiple disciplinary discussions that were had about what's the safest thing that we could do for this child in order to move them safely, but also get them to the right place for their right care. So I just want to talk a little bit about mediastinal masses and what are the considerations that we need to think about. So mediastinal masses, almost half the time, are found incidentally. They might also be some presenting features such as fever, night sweats, weight loss, and pain. And certainly with the case that I presented earlier, it was with cough and fever. The other signs and symptoms that they might display is orthopnea, so breathlessness on lying down, cough when supine, stridor, wheeze, syncopal symptoms, certainly when the mass is large enough to impact on the cardiovascular system, and upper airway edema. When imaged, you might find that there's a reduction in the tracheal cross-sectional area. They could have coronal or bronchial compression, which certainly the case that I presented had. You could have great vessel compression and also pericardial effusion because of the reduced drainage. The main concern that clinicians have with mediastinal tumors is the anesthetic risk that comes along with it. This study looked into 63 patients, and of 55 of those had non-Hodgkin lymphoma, and it was found that 15% of them had problems during the time of intubation and ventilation and developed cardiovascular collapse during general anesthetic. So not an insignificant amount by any means. And that risk is greatly increased when there's tracheal or vascular compression or more than 3 respiratory symptoms. So if you reflect back on the case that I presented, this young man had tracheal compression, SVC compression, and was already tachypneic, though luckily he was not hypoxic. The management options, as I've highlighted earlier as well, is all to do with multidisciplinary care. This is not something that any singular team will be able to manage on their own. And if possible, if you can get all the teams within one unit and one center together, that will be most ideal, but you must also have to consider multidisciplinary care from several centers combined into one, perhaps, conference call. So not least the oncology team, the cardiothoracic surgical team, ENT, anesthetics, and the PICU, potentially even with ECMO capabilities to manage these cases, specifically when they're on the severe end of the spectrum. I'll go through our transport considerations, specifically because this is probably what's most interesting to you. This is based on a paper that was presented, published by Dr. Linda Chigaru and her colleagues about the pre-transport assessment and planning. I'll break this down into bigger images so you can appreciate it better online. So in terms of the pre-transport assessment and planning, as I've mentioned earlier, it is all about early involvement of multidisciplinary teams and having that discussion early on about what the particular risks are to this patient geographically, and also what's available within the region to support the management of this patient. So not only the referring and the receiving medical team should be involved, but also the transport team, the oncologist, the intensivist, the anesthetist, the surgical team, and the radiologist. You need to consider what initial investigations you can do locally, in which case, the case that I presented earlier, he was able to have a CT scan of his chest as well as a chest x-ray. There was no local availability to do a lung ultrasound, but again, that's a bit of a moot point now there's a CT, and also to consider an echocardiogram if there's any cardiovascular involvement. When you do a risk assessment, you need to consider what signs and symptoms are already available, and also what imaging findings that you have that will constitute a high risk for this patient. And so similar to what I explained in the presenting complaint earlier, whether the patient has orthopnea, any stridor at rest, cyanosis, shortness of breath, syncopal symptoms, engorgement of veins. And then when you look into the imaging findings, once that's available, whether there's any narrowing of the airway tree, any displacement of it, any compression of the great vessels, and any evidence of effusions, pericardial, pleural, or elsewhere. You also then need to consider whether it is vital for this patient to be transported at all, because obviously not all mediastinal masses are high risk, but not all of them need immediate intervention within the next few hours. So you also then need to consider whether this patient should be moved out of hours, or is it something that you can do safely in hours, should the case allow it. And this is, again, not a singular decision that should be made by any one team. It should be involving all the different multidisciplinary teams. You then have to consider the destination of transport. And this is all, of course, variable depending on where the patient is and where the patient is being referred to, because not all places will have a tertiary oncology center. Certainly not all places will have cardiothoracic surgical units or ECMO center or ENT support should they need it. So this has to be weighed up really carefully depending on the geographical location of the patient, as well as where they need to be transferred to then receive their care. Once it's decided that this patient does need moving and the place, the receiving center is then decided, you then need to consider how can you stabilize this patient enough for them to be able to be transported. The main thing that I want to highlight about mediastinal masses is that the patient's position is absolutely vital. Most likely, they would have presented to the A&E department self-ventilating, but with some signs and symptoms of mediastinal masses. So if they are already self-ventilating and they're managing to oxygenate and ventilate themselves well, then there's no reason at that point in time for you to intervene if you can safely transfer them in that same manner. Always consider, of course, the rescue position. That will be the most ideal for them, depending on the side of the mediastinal mass, and whether that would have any compromise should you put them in certain positions during transfer. And if at all possible, with the transport trolley, you can elevate the top head, the top end of the trolley, so that you can elevate the head to help with the SVC drainage. As I mentioned, if at all possible, you can try and avoid intubation and ventilation, because you want to avoid positive pressure ventilation and the effects that might have on the mediastinal mass. You also want to avoid any sedation agents, specifically if the patient's in a local hospital that does not have pediatric anesthetic cover at that point in time, just because that if you are sedating a patient, they might then develop respiratory depression, and you might then end up in a very difficult position where you're then going to have to do a crash intubation and manage them locally. And certainly if you're avoiding sedation, you should also think about avoiding neuromuscular blocking agents. When prior to transfer, you might need to consider their fluid status, whether they're going to need any pharmacological support. And this could be various things such as fluid boluses, inotropic support, certainly antibiotics if they need it. And also, when you think about placing intravenous access, try to do that in the lower limb, just because if you were to insert one in the upper limb, they might have SVC obstruction, which then will delay the delivery of the medication that you give. Certainly, if you were to give resuscitation boluses of fluids and medication, that would then impede on the delivery towards the central systems. There are some things that you need to consider that are particularly high risk that you want to consider for particularly high-risk cases such as steroid therapy, chemotherapy, or radiotherapy. Now, bearing in mind that most of our local district general hospital will not have these capabilities, this is something that we really only leave for specialized centers, transfers from tertiary to maybe quaternary centers. You might want to consider intubation before transfer if they have any signs of airway, breathing, and cardiovascular compromise, and consider whether they might be appropriate for pre-transport femoral cannulation in ECMO on standby. Now, again, these are for extremely high-risk cases, and certainly this is not something that's taken lightly and requires that MDT approach again, as I've mentioned. Now that you've stabilized the patient enough for transfer, you need to consider how would you manage this patient should they deteriorate during the transfer in itself. And based on what we've discussed already, the main concern would be if they were to develop any respiratory collapse or cardiovascular collapse. So if there is a potential for respiratory collapse, you need to consider how would you want to minimize that hypoxia. And so do you have quick access in order to increase the oxygen supplement? Do you have any access to non-invasive support that might be suitable for the patient? Because as I've mentioned, you want to avoid intubation and positive pressure ventilation as much as possible. Are you able to reposition them to adopt a rescue position, such as leaning forward or leaning away from the side of their mediastinal mass? Think about the application of CPAP, as I mentioned, with NIV, and how can you optimize the parameters of the cardiovascular system in order to then support the respiratory system. And should the patient have a cardiovascular collapse, you need to consider how you can maintain the preload as well as the cardiac output. The easiest thing in this case would be to give a fluid bolus, and again, to reposition the child to allow gravity to help and aid the patient respiratory and cardiovascular system rather than impede it. And also optimizing all the parameters here in terms of the blood pressure and lowering the tachycardia, however way you can, whether it could be from giving pain relief or for the fluid boluses at this case. So in summary, we've had a look at the CATS upper airway obstruction data in 2023. I had a very brief overview of the differential diagnosis of upper airway obstruction. And the main thing to take away from that is that it is extremely varied. I talked about the local challenges that we face at CATS whenever we presented with these particular cases. And I went through a case of a very significant mediastinal mass in a patient over the past month, and what we did in terms of safe transfer for their ongoing care. And I also talked a little bit about what the considerations are for transport when you do face a mediastinal mass. I've got some time for questions, so I will just unshare my screen. There we go. And I'll just open up the Q&A, and I'm happy to take any questions on there.
Yes, thank you, Amira, for that really exciting case. Actually, it's quite relevant for us because we had several of them in the last year, as I remember. So it's a very high-risk case, which you really have to educate people on, I think. Clary, do you have something to add or question in the meanwhile until people are typing in questions in the Q&A box?
Yeah, thank you very much for this very interesting presentation. I think you really kind of highlighted the most important points. Do you know some data, like how many of mediastinal mass cases do you see at CATS, like in a year, or what is your?
So based on the data that my administrator was able to pull from last year, of the 35 cases that we had of some form of upper airway obstruction, 3 of them were with mediastinal masses. So certainly of the numbers that we see that's referred to CATS, that's extremely small, and that's why it's kind of dealt with from a case-by-case basis. So certainly there's no one answer fits all.
Mm-hmm. And did this patient need intubation or any respiratory support, or you were able to transfer them without?
Majority of the time, they are transferred self-ventilating just because of the risk of intubation. And at most, they probably have needed nasal cannula oxygen in terms of respiratory support. The main pathway that we do is that to get them to a PICU so that they can have the initial assessment and management of their mediastinal mass, and whether that could whether it could be non-invasive support, for example, which they won't be able to deliver on a ward, and also to then start their emergency therapy, usually in the form of steroids. And in PICU or a critical care unit, they'll be able to monitor for tumor lysis syndrome much more closely.
Thank you.
For question here, what does exactly ECMO pre-cannulation mean? I think what this refers to is mobile ECMO, and certainly this would be does that work? And certainly this will be in very extreme cases. It's not something that I've come across in my experience. But what that means is that if the patient is so unstable, do they need to go onto mobile ECMO? In which case, within the UK, we have a mobile ECMO unit based out of Leicester, who are able to mobilize to areas within the UK to cannulate the patient, to start them on a mobile ECMO before then transferring them onwards to a ECMO center. This is extremely rare.
Thank you very much. Did I understand it well that the patient was given chemotherapy before the tissue biopsy was done, so the pathological histology was done?
That's right. So with this particular case, because the patient came in before the weekend, plus he was such high risk for general anesthetic, they felt that it was best for him to at least have something to reduce the tissue bulk of the mediastinal mass. In that sense, he had his emergency chemotherapy. We're bearing in mind that that could potentially affect the histological biopsy result. What I didn't mention was that actually even from the CT scan, it looked very likely that this child has Ewing sarcoma, because the mass was arising from the right first rib. And so that made the oncology team, as well as the interventional radiology team, happier that he could have a delay between the emergency chemotherapy and the actual histological biopsy.
All right. Any other questions? Maybe in the chat? I don't see anything now.
No.
Clary, do you have anything else, or are you happy to continue? All right, so then thank you, Amira, for this exciting
Thank you very
talk.
much.
It's really, really relevant for us and really interesting. Not only from the hospital care, but also from the ICU phase as well. So thank you. All right, so we then go on with our second part, and during which you can also type questions not only for our part but also for the first two presentations, I think, and we are going to do that in an order that I'm starting with some introduction about our service and some general things about upper airway obstructions. Then Clara is going to take over about the statistics and the cases and the audit she performed as well. And then I'm going to end it with some other cases and summaries as well. So to introduce ourselves, we are actually part of the Hungarian National Ambulance Service, which is a national general service covering all the pre-hospital care in Hungary. There are, however, several foundations who do specialized, in our case, specialized pediatric pre-hospital emergency care, which was implemented in 1999. So that's why we are 25 years old now. Back then in 1999, it was really a volunteering work of young pediatric anesthetist and intensivist in Budapest. but we should not forget the enthusiastic team of nurses and paramedics and technicians who, until up to this day, until today, form a very stable basis of our work, and we are very thankful for their support throughout these 25 years. This is Hungary, located in Central Europe, with the bordering countries, and we just highlighted the three main regions we are involved with. Actually, there are several other pediatric ambulance services in other parts of the country, but these are the three regions we are involved with. And since we don't transfer neonates and premature babies, there is also a separate service for premature transport with incubators. And also on top of that, there is an air ambulance system working in Hungary, covering all the regions of the nation. These are the four units we have. The top one is the oldest, which is a so-called pediatric MICU with the doctor on board, doing about 1,600 cases a year. But we also have two other doctor-led units, which are located in Miskolc and Debrecen and their surrounding neighborhoods. They operate every day, but only in daytimes. And we also have our latest venture is a so-called pediatric nurse or paramedic-led unit in Budapest, which has no doctor on board, supplied by our colleagues who also work on our doctor-led car. It is only operating for 6 years now, but since it only operates on weekdays and on daytime, we see that the caseload is very, very high, and they cover lots of cases, which is very optimal to keep the load of the doctor-led units older. So this is how our ambulances look like, and this is only to highlight that beside the high quality and the equipment, we really like and really have several additional things compared to the National Ambulance Service general units. We also, at the same time, we also keep very close eye on being child friendly and being a good environment, not only for the patients but also for the parents as well. So what we do, actually, there's a big difference between the London team and us, because we also do primary pre-hospital cases. Actually, most of our cases are such, and the four categories are similar to the London ones. So respiratory cases, neuro with status epilepticus and similar kinds. Minor to major burns and skulls is quite top on the list, and trauma care is also one of our most frequent cases. We also do secondary, so inter-hospital transport, which is about 20% of our work, which actually includes not only transport but also stabilization, like in London Ambulance. And also, it's quite important to mention that our cases are located on a very wide range, because we really our aim is to reach the sickest babies and children, but in reality, owing to the difficulties in dispatch system, patients range from really a GP level, mild grade fever, to the sickest cardiovascularly unstable kids. So that's a very wide range of patient severity. In terms of our equipment, it's a list of what we have on top of the standards of the National Ambulance Service. We are proud to have now a mobile ultrasound and the blood gas device on all our units, which are not everyday used, but can come in very useful in cases. Regarding blood gas, we found that not only the ventilated children, but also children with unexplained convulsions, suspicion for intoxications, and several other situations, it's very useful to have a mobile blood gas device. A video laryngoscope is also not routinely used, but we have it in Budapest, and it's, for example, specifically in upper airway obstruction cases, when you have to intubate, it can be of a huge help. An MRI compatible ventilator is our best friend in Budapest, because we do lots of MRI transfers, and that makes our life much easier. And obviously additional syringe drivers and this thoracic drainage system, which we don't use very often, but can be also very useful in cases of persistent air leak. These are our top equipment we are proud of. We also do education. We try to do it as wide as possible. So we give pediatric first aid and BLS practices for public people, but also healthcare workers are also involved, partly online, and practical activities are regularly held. So far, we only did it in Hungarian, but hopefully from this year it's going to change. And we are very proud of our ultrasound pre-hospital and point-of-care pediatric emergency ultrasound course, because it is not only something that's good for the ambulance, but also for the in-hospital phase. And I would like to thank my colleagues who supported this course, for example, with their own kids. So thank you for them. We also do internal education and simulation trainings regularly. I think they are very, very important. And also it's really a must for all the doctors to do the EPALS course, which is the correspondent of the APLS, but in the European region. Just some basics on upper airway obstruction pathophysiology. Really, without going into details, Amira showed us the difficult classification systems, and on the right side, it's just a very basic image which I'm sure all of you learned sometime from biophysics or for physiology. This is only to show the effect of a very low narrowing, so only 1 millimeter narrowing, circular narrowing of the baby airway, which can lead to at an extreme high increase in airway resistance. So that is something we really have to keep in mind when dealing with such babies and children. This classification is actually taken from the CAPS website, and we also find that the viral laryngeal tracheobronchitis, so simply to say, the Krupp syndrome is our most common case, and you will see it in Clarice's presentation. But we also, as a tertiary center, we quite frequently see foreign bodies, inhalational injuries, anaphylaxis, and ENT cases like retropharyngeal abscess. Without going into specifics in treatment, just to say a general thing, which is, I think, the most important, as also Amira mentioned, to relieve the anxiety of not only the child, but also the family and the caregivers. I think the most important thing is also not to upset the child. So we should avoid any unnecessary tests and treatments like sticking in a tongue depressor, making repeated blood tests, unless really necessary. Even getting IV access is reserved to cases which we really want to give some IV form of medications. When possible, we should leave the patient with the parents in a comfortable position, and it's also important that the position of the baby or the child is an important thing to document and consider, because it can give us some hints about what the problem may be. In group. All right, and before going into the specific cases, I would like to hand it over now to Clary. Could you please share your screen?
Okay, thank you, Gyula. So I would like to continue with this after this excellent introduction of Szent Marton, with some summary of the cases from the past 2 years regarding upper airway obstruction. So just a reminder that our units do not cover all of the 3 physician-led units and 1 transport nurse-led unit. In terms of our methodology, I just would like to the ambulance units, they use a tablet-based software for electronic data entry, which is mainly a structured data entry system, but there are also spaces for free text, which sometimes make our lives a little bit more difficult, because we had to use search terms to find all the airway obstruction cases. So we search for specific diseases as well, and for specific symptoms as well, to have a biggest pool of cases which we can find. So altogether, we had more than 5,000 cases in the past 2 years, and out of which 5% were upper airway obstruction. If we have a closer look to this, we can say that Krupp syndrome was the majority of all cases. Second being foreign body aspiration, but we also had some cases of retropharyngeal abscess, subglottic stenosis, and other congenital malformations, and 1 anaphylaxis as well. This table is to show you some data about the specific disease groups, to get a feel what do we do out there. So what we can see that the mean age, both in Krupp syndrome and foreign body aspiration, was around 3 years, with a large standard deviation. Cases with retropharyngeal abscess were a little bit older, and with subglottic stenosis were a little bit younger. As Gyula mentioned, that we both do primary care and secondary transports. And what we can see here is that the retropharyngeal cases, retropharyngeal abscess cases, were all basically secondary transports, and 2/3 of the subglottic stenosis cases were also secondary transports. Some of the foreign body aspiration cases were also secondary transports, and the majority of Krupp syndrome was primary care. Our nurse-led unit also played some role, especially in treating the less severe cases of Krupp syndrome and some of the cases with foreign body aspiration. You can also see our stabilization time, and it's very different for Krupp syndrome and foreign body aspiration, which is basically primary care. It's around, on average, 20 minutes. However, in retropharyngeal abscess cases and subglottic stenosis cases, these were longer, so around 70 minutes, because of the in these cases, we had to take over from patients from ICUs, or we had to intubate them, etc., which obviously took longer. We also see how severe these cases were by watching at how many transports happened to ICUs. And we can see that Krupp syndrome cases, only 1% needed ICU care, while 6% needed ICU care in foreign body aspiration, and much more cases were transferred to ICUs in retropharyngeal abscess and subglottic stenosis cases. And we can also note that around 10% of the cases of Krupp syndrome were not required transfer to the hospital. So parents could manage these kids at home. So as Krupp syndrome was the most common case, I would like to kind of summarize the protocols which we use at the National Ambulance Services. So the idea is when the parents call in, that the call taker will kind of take the Krupp score, which is a Krupp score like specifically used at in Hungary, so it's not the same as what is used worldwide. And according to that, we can create categories, and we can decide what level, what unit level is needed to treat this patient. So, for example, for mild Krupp, a transport nurse-led unit should be enough, but for moderate Krupp, either a paramedic-led unit or a pediatric unit, if it is close, could be used, while for severe Krupp, a pediatric unit is indicated. So when we are with the patient, we can, Sidula kind of summarize the most important parts, that positioning in a child-friendly manner, to avoid painful interventions and unnecessary stress is very, very important. Also avoiding examining the oral cavity. And of course, we use an ABCD approach. For mild Krupp, in terms of medication, what is suggested primarily is dexamethasone orally. If it is not possible, then rectal prednisone can be used. But for moderate severe Krupp, next to steroids, we should use inhaled adrenaline or racemic adrenaline. And if oxygen is needed, then we prefer to give it free-flowing and not to force a mask to the child's face. The next few slides, I would like to show you the reality. So unfortunately, the Krupp score is not documented by the call takers. And unfortunately, the units only documented it in 31 cases. So on the right-hand side, what you can see is that these 31 cases were moderate Krupp, but we had some severe cases as well. We only had one intubated case, which was intubated locally by the local hospital, and we transported this patient to the PICU. And how well do we do regarding medications? So what we saw that steroids, would you mind taking over, because my voice is
Yeah, no problem. So we discussed with Kari. She unfortunately has a flu, so that's why we discussed to have this few slides giving together. So what this the aim of this audit was, and this part of the slide was to see if we keep up with the protocol, and steroids are given as per protocol in these cases. But what is an important finding, and maybe there is some room for us to improve, is that there were several cases. So this 23 cases were cases giving adrenaline without giving steroids before, or at least it wasn't documented. So it's quite against the protocol, because it's really a must to give steroids in all cases. And on the next slide, we are going to see that it's also proven in the literature. So it's really the left one shows a change in group score 6 hour post steroids, and all the studies favor glucocorticoids instead of placebo. And then the right one is the number of return visits or readmissions, and the same. And we can observe the same with all the studies mentioned. So it's quite a clear thing, starting with steroids. Also, because contrary to what we thought earlier, steroids can actually act quite fast. So their time to effect is less than an hour in these cases. So go on with foreign body aspirations. Some points to learn were that clinical signs were only present in around 5% of the cases by the time the ambulance crew arrived. In the audit, there were no complications during transport, and obviously, among the secondary transports, the cases were of higher severity, with aiming to higher level of units with bronchoscopy or ECMO capabilities. There were also several cases of retropharyngeal abscess or other ENT surgical groups, which were actually owing to the fact that actually, unfortunately, in Budapest, we have several small hospitals located quite near to each other, and there's unfortunately no big central pediatric hospitals capable of doing every kind of surgical and diagnostic procedures. And there were quite a few cases of ventilated transport and fourth operating room between the peak intubated. Also, this audit mentioned the cases of subglottic stenosis, was actually unknown, and there was a difficult airway with unsuccessful intubation transported on LMA. I think we wait a few seconds until all the others are here. So, do you think you can take over recording again?
Yeah, sorry about that. We lost connection.
Yeah.
We're back
Okay.
recording now, so you can continue. Sorry
All
about
right.
that.
Thank you. No worries. So that was Clari's part, and then I go over with the different challenging cases, maybe. So case number 1. This was actually 14 years back in time, so I was quite a junior member of the pediatric transport team. The case was about a 4-year-old girl. She was very severely disabled, living in a nursing home due to the above listed conditions. She had a tracheostomy and a gastric tube in place for some time. And in this case, she developed a respiratory tract infection with secretions and gradually increasing dyspnea. What we found, she was already in hospital in a small pediatric unit, was that she had diminished breath sounds on both sides, severe dyspnea with nasal flaring and retractions. Oxygenation was maintained, but only on high flow oxygen, partly to the tracheostomy site and to the mouth as well. The caregivers and also us were unable to pass the suction catheter, and the patient had no IV access at that time. The plan which we were asked to do was to retrieve this child for a tracheostomy change by the ENT surgeon in a nearby hospital. The estimated transport time was 15 minutes. And to make it a bit more interactive, I would like you to vote, for which I have to think the sharing adjustment, sorry. So could you please vote which one is the best management option by the retrieval team? If you were the retrieval doctor and scene, you can either vote through scanning this QR code with your device, or there's also a possibility to go to slido.com, and the event name is CATS 2024. So we wait a few minutes until we see if it's technically feasible, and then maybe there will be some interesting results. So again, the question is, what is the best management option by the retrieval team in this situation? So basically, obstructed tracheostomy tube with maintained oxygenation but severe dyspnea. So probably the patient taking breath minimally through the stoma, and maybe besides it from above is reaching the lungs. So the options would be remove the tracheostomy tube and intubate through the cords, replace the tracheostomy tube with an ETT, replace it and mask ventilate through the stoma is also a possibility, transport as soon as possible, or take an urgent X-ray to rule out any other conditions. Okay, I think I give you 1 more minute to vote, and then we are going to discuss the results. So the most popular answer was to replace the tracheostomy tube with an endotracheal tube, and actually I really agree, and that's the most appropriate thing I should have done in this case. But that time, unfortunately, I was convinced that we should transport this child. And what actually happened is that we transported her with the stoma in place, and then actually arrived in the nearby hospital successfully with no major complications, but maintain oxygenation. But the point is actually really well done by you voting. So and by that and after that time, in the last ePulse course manual, it's also very clearly stated that if a suction catheter in a tracheostomy child cannot be passed or suctioning is unsuccessful, the tracheostomy tube should be removed immediately and replaced. And what actually happened in this case was that in the ENT operating room, the tube was removed by the colleagues there, and instantly there was a sigh of relief, and the spontaneous ventilation was completely effective that time. So the problem was really the blocked tube. And if you think about it, it's really a very simple thing, but a not so simple decision to make, because if you think about ABCD management, then actually it's really an A problem, and you shouldn't jump over it without fixing the A problem. So what I would suggest to do is nowadays is to really on scene removing the tube and then either replace it with an AT tube or a spare tracheostomy tube, or just figure out something else, but removing it is really a must in this case. Nowadays, it's also got better in terms of documentation. Also, in the pediatric intensive care unit where I work, there is this labeling already in use. So if any patient has a tracheostomy, or specifically if any patient has a new tracheostomy, which really matters because it changes the treatment options in such a case, there is a clear labeling over every bed telling you what size, what depth, and what any other things to know is regarded with the patient. All right, let's go over to the second case, which is about a 9-month-old boy without any previous medical history. He had bloody vomit 3 times since waking up before their call. Then the ambulance service was called, and by the pre-hospital pediatric team, the patient was retrieved from home to actually our pediatric clinic in an ABCDA stable condition. They found minimal bloody saliva on floor. The parents denied any. There was no suspicion at that time of any foreign body ingestion or aspiration. The transport was otherwise uneventful, and also the patient arrived in the pediatric ED in a quite a good condition. But suddenly, he appeared very sick. Developed dyspnea with stridor and wheezing at the same time. He also had sternal retractions with an elevated respiratory rate, maintained oxygenation on supplemental oxygen. He was quite tachycardic and agitated at this time. So he was transferred to the PICU, was given an IV fluid bolus, also an IV dexamethasone, and inhaled racemic adrenaline was applied, but without any significant improvement. An abdominal ultrasound was negative, and they performed a chest X-ray as well, which was also negative. At least no gross abnormalities or gross visible foreign bodies are seen now. And now I would also like you to vote through Slido, for which I'm sharing the screen again. So the question is, and you can vote for several things now. The question is, which further diagnostic studies are necessary in this case? Is it a bronchoscopy necessary? What do you think? Do you think there's a sepsis workup with laboratory tests and the point of care testing necessary now? Do you think that a repeat X-ray of the baby or a repeat abdominal ultrasound is necessary? So these are the treatment options, and as I said, you can vote on several things at the same time. All right. So I think we can go over because bronchoscopy won, and really is something which is really makes much sense. So I think we get back to the presentation now and go over with the case. And what actually happened is the bronchoscopy was done by my pediatric pulmonologist colleagues. And really, at the beginning of the bronchoscopy, when they this started to go in from the nasal route, they found a foreign object in the laryngeal inlet. And what you see here, hopefully also the video starts now, is a small part of the toy which is obviously very attractive for such a young boy. And maybe the case was that he swallowed it without the parents noticing it. With what is at the same time very frightening thing is that this small object contained 3 very small bottom batteries, which is well known to be really, really toxic and dangerous for babies like that, in case they got stuck somewhere in the GI or respiratory tract. In this case, the kid did really well. So fortunately, after a few days, so it was removed with a laryngoscope, really normally, directly by my colleague. And after a few days, he had a repeat endoscopy and no permanent injuries happened to the pharynx and larynx of the kid. So the baby did really well afterwards and was discharged home. Maybe a very interesting point is that this was missed on the X-ray, probably because it was up to the highest border of the region about which the X-ray was taken. So it's quite a learning point that this can also happen. Only one tracheal problem, so subglottic stenosis or subglottic problems, to be more specific. This video, without any really detailed case description, was taken by also my very nice colleagues from pediatric pulmonology. They performed a bronchoscopy, an elective bronchoscopy in this baby who had stridor from birth, and they now enter the trachea with some lidocaine sprayed partly at the cords and partly into the trachea to prevent coughing during anesthesia. And what they found just above the carina was a clear airway narrowing, which later turned out to be a vascular ring, so something from outside compressing the tracheal wall, which is very clearly visible here. Even the pulsation of the heart and the great vessels are seen now, and that's what's also possibility in case you have a patient with stridor. So as a summary, I just wrote up 3 things. First, my really big learning point from my own mistake was to always remove the blocked tracheostomy tube. The second one is foreign bodies can be missed on X-rays, partly because they are radiolucent, or partly because they are not on the imaged region. And the third one is maybe that not every croup is really a croup. So in case a croup patient doesn't get better while treating, maybe you should think about other conditions. And maybe this webinar was good for thinking outside the box, and besides taking a closer look on croup, also touching several other things which are interesting. All right. If anyone has question, then we have now plenty of time to answer them. So please, if you have questions, then anonymously put it in a Q&A box. And I also asked my panelists group if they have anything else to add or anything to ask to the second part. Clary, are you all right now? Okay.
Yes, thank you.
So there is one question which is the following. So how are these ambulances prioritized and coordinated with the Hungarian National Ambulance Service when responding to emergency calls? Are there separate call handlers, dispatchers dedicated to the unit? Thank you for this question. The answer is actually we have no separate dispatch center, which is at the same time good and a bad thing to have. It's good, I think, because there's really one system in Hungary which is located physically to several other dispatch centers, and all the calls are recorded. All the calls go into an electronic system, and the dispatch is also electronic, so there is no paperwork included these days. And the coordination is done by professionals sitting in one of these centers. Of course, there's lots and lots of points which can go wrong, actually, because this has several reasons, but a good dispatch center needs not only very good professionals, but also good citizens who can ask questions and give calls in a normal and educated manner, and that's unfortunately not always the case. So it's a really difficult job to dispatch ambulances, but the aim of our dispatch system is to get to the sickest babies primarily, so as a primary call, or if the ambulance unit on scene feels that it's out of their comfort zone, they can also call us through the ambulance system. Is there anything other, Clary, you would add to that? Okay, the second question is, what opportunities are available for patient follow-up after transport, both in Hungary and the UK? In Hungary, it's unfortunately a thing which we really wanted to do, but can only do currently unofficially. So in our team in Hungary, it's quite a small team. So we really, on a daily basis, we phone each other and write each other and get information from the baby transferred yesterday. But there's unfortunately no formal and legally normal way of getting information. Hopefully it's gonna change, but nowadays it's the situation. How is it in London? Do you have any such opportunity, Amira?
Yeah, we do. In CATS, we have a formal follow-up service that we do. We have some fellows who are available in a non-clinical day who will call up after 24 hours that a case is closed. And this is all cases, not only just transported, but also those ones that are closed on advice. For example, we'll get a follow-up. We have a pro forma that we fill in our electronic data recordings system, and that's where we will then flag any necessary reflections or anything that we need to follow up on further. We also use that time to help us audit some particular projects that we're working on. Currently, we're looking into what's happening with our status epilepticus and several other QI projects that we're working on. So that's quite useful for us.
Thank you. That's really something that we should follow, because that would be a really big opportunity for us to improve, and also for some data gathering and scientific purposes as well. There's one more question about, I think, mic talk. During the removal of the tracheostomy tube, should we use some kind of Seldinger technique for example, a bougie. I think this is a very good idea, but I would mostly do it only for a new tracheostomy, because during exchange of a new tracheostomy tube, the biggest fear of ours is to lose the track, and in case it's a fresh tracheostomy tube, so like only a few days old, then that's really high risk situation, which I would rather do in a very controlled environment with ENT surgeons or pediatric surgeons on board. In these cases where you have to emergently exchange a tube, you can use any kind of like bougie or Seldinger technique, but I think you always have to make sure that any sharp object or any rigid object is dangerous for small airways. So you only have to do it, you only are allowed to do it in case there is no forcing of this bougie, just smoothly passing it. All right. Is there anything, Izzy or Clary, you would like to add or ask?
There was something that Amira and I were discussing, and we were reflecting on the fact that your population for your country is the same as, if not a similar population for just the London region.
Yeah.
So we were reflecting on that, and you know, the difference in sort of, or the similarity in the demographic population, and how, well, I mean, we think it's really impressive that you managed to do pre-hospital and inter-hospital transfers. That's obviously very different for us, because we are secondary transport, working alongside other critical care transport services, and then we have the St. John's ambulances that cover each different region across the country. So yeah, no, that was something that we found quite interesting, actually.
Yes, we discussed this also with Clary, that it's a huge difference. There is a lot, maybe a last question here written. Can we say croup is more common in Hungary than in the UK? I have no statistics about that, but I'm not sure. I don't think that's the case. Clary, what do you think?
I do not know exact statistics, but I don't think we have any reason to think that there is a difference in incidence of croup.
Yeah. Izzy, do you currently have lots of RSV cases, bronchiolitis?
Yeah, RSV, mycoplasma, some flu A, and that we're seeing at the moment. Yeah. And in terms of croup cases in the UK compared to Hungary, I also couldn't tell you, and Amira's just stepped out to take a call. So we wouldn't be able to comment on that either. We found it quite interesting, though, the amount of boys, the male population, in your data who have had croup. But other than that, no, we wouldn't be able to comment. Something to look up.
All right. Okay, so I'm very happy to have done it successfully, both technically and professionally. It was very nice for me to see it, and I think really I can say from all of my team that we are really thankful for you to make it possible. I hope that those who couldn't join online can also see the presentations afterwards from the CATS website. And it was really an honor for us, Izzy. So thank you very much indeed.
And thank you. I'm relieved. I'm apologized that there was a slight technical issue. One of our meetings ran over with another one, so we had to escape from that room really quickly, and then the Wi-Fi seemed to give up on us. But no, thank you so much. It was a pleasure to collaborate with you and to exchange you know, details about cases, and just to hear a bit more about your team. And hopefully we can do this again in the future. And as I mentioned in our presentation, we're open to observership. So if anybody ever wants to inquire, then please do. I know, Clara, you have worked with us at CATS So perhaps if you're in touch with Clara, you can reach out to her, and she will provide you with some contacts and some information.
Absolutely, yeah.
All right. Okay, so thank you very much for everyone for joining, and have a nice day. And thank you again.
Thank you so much. We will
Thank
post
you.
the recording of this on the CATS website very shortly. So if you just go into Google and put in CATS Transport Service, you will find us on there.
All right.
So yeah, thank you so much.
Thank you. Goodbye.
Everyone,
Goodbye.
take care.